Hello, I am Kim Jin-gyu, Master Course Director, and today I'm going to talk about the full mouth rehabilitation using the OneGuide system. Now, in case of full mouth case and doing guide surgery, the biggest challenge is temperate positioning, its accuracy, because natural teeth, if it exists, then when you use guide, it's very accurate and it's very easy to check its accuracy and it doesn't really move. But if it's edentulous patient, the guide is mobile and the denture does not really move on the upper side, but for the guide, it doesn't really cover everything. So it also can become mobile on the upper side. So upper and lower side template moves, and there is also it can be also be in inaccurate position. So this could result in error. And to do such error, we use anchor pin in the OneGuide system. So you put using the anchor pin, you put in the accurate position. You know about the lateral anchor pin, but using lateral anchor screw template to the bone and gingiva, it fixes. So we design on the 3 points, and if you anchor on these 3 points, the anchor screw holds on to the bone, resulting in accurate positioning of the template during surgery. So to use anchor screw, use anchor drip to prep the site, and anchor driver is actually mount driver, and using that you make it stable and fix into the position. So again, at least 3-point anchor for solid fixation, and it has used octa screw, so you spin it to put it into position. However, that when you use lateral anchor pin, it really works, but sometimes actually it's only 3-point fixation, and on the mandible side, you fix it on the labial and buccal side. So one side, there could be big gap or it becomes mobile. So inevitably, then the path changes or the position could change. So to reduce such errors, vertical anchor pin has also been developed. So lateral anchor pin, you put it directly on the bone, but the anchor pin, there are 2 types. Vertically, there's a bone anchor going direct to the bone, or if the implant has already been placed, then fixing to the implant itself. So it used to be called fixed anchor. So bone anchor, as it says, you drill and it fixes to the bone anchor directly rather than fixing to the labial side. Of course, that is also helpful, but during surgery, if you additionally do this, then it doesn't become it becomes less mobile, so you gain stability, and if you had placed implant, it becomes safe on the back side, and if you fix it to the existing placed implant, then without becoming mobile, it becomes very stable. So vertical anchor pin is also something you also use during surgery. Now, in terms of fixation types, lateral anchor, vertical anchor can be used. And one more thing, in case of the full mouth surgery, besides fixation, you might be uncertain about the path accuracy. I also do a lot of full mouth surgery, but sometimes also I'm not sure. So there's one more way to check for accuracy of the path. So after putting the anchor to check the path, you use the drilling path for path accuracy check. So if after delivering, taking the CT, you can check whether it's accurate position. So use this tool. So you know about lateral anchor tool. So let me talk about the vertical anchor tool. You use twist drill diameter 1.5 and using this bone anchors, and if there is an implant already placed, use implant anchor for fixation. So bone anchor, you drill and then you put the bone anchor there, and the implant anchor, it links to the implant. So this guide barrel area of the implant anchor touches the guide and very stably fix it into the position, and you can push actually down. So on the tissue side, the guide is pushed so that it stays into the position. As I said, whether there's a lateral anchor or not, of course, lateral anchor is always planned, but you put in the anchor screw or using implant anchor or bone anchor. Then during surgery, you can actually deliver implant in the accurate position without mobility. So bone anchor, implant anchor, in my experience, if you use them, the accuracy really goes up. And in usage, as you know, regular size and wide size do exist. And you know how you use it. As I said, you drill first and then you put in the anchor and fix the template into the position and place the implant, and you put it on the next to it. Then in the already placed implant, using the implant anchor, additional stability can be gained. As I said, there is also CC check it, and if you put it and take a picture, then if you place implant like this, whether it goes to the place I want can be checked beforehand. So there's MS, regular, and wide type. So there are a variety. So if you are not sure, especially on the anterior lower mandible side, if you check it first, you can become more confident. But I think OneGuide is actually very accurate in my experience. And if you just deliver it without checking first, accuracy, you don't lose much. But if you are not experienced, using this type of tool can be helpful. So let's look at some case on the RPD on the maxillary side as well as mandible side. And here there's a lot of damage. There's a lot of mobility. So we try to do OneGuide restoration after extraction. So on the mandible, there's a lot of recession mobility. So we extracted teeth, and after that, using the guide, implant was delivered. So the bone was not sufficient here. So we did GBR, and here I used Osstem and then did GBR. And as you see, the path is really good. Actually, and dental mandible side, I placed 6. So here from canine to canine, and then the first premolar and the first molar are usually connected for restoration. After that, it's healed very well. Prosthesis was delivered, and when you deliver prosthesis, actually it's three piece. You divide it into 3 pieces, 3 unit and 6 unit, and again 3 units. So you separate the anterior and the posterior side. That's more favorable. So I do that. And after prosthesis delivered, you can reduce number of implant, and patient also find it comfortable. Of course, there are other ways, but for Koreans, especially this type of step-by-step approach is very helpful. But if you don't use guide, the implant path becoming accurate and delivering prosthesis later on, whether prosthesis would have good shape, I don't think so. I do a lot of surgery, but if it's full mouth case, Edentulous case, if there's no reference point, it's very hard to find the accurate positioning. And buccal-palatal path is also very hard and challenging because you don't know opposing teeth. So if you're not unsure, use the OneGuide system and use all these tools so that you can have more confidence in making prosthesis and delivering that, hence guaranteeing a more successful result. So thanks to the successful implant placement, the patient is using prosthesis very well. Next case, young, 40s male patient, and as you can see, there's a lot of teeth loss. So mandible and maxillary side, we planned for implant placement, and posterior I tried to use it as is, but on the upper side, full restoration. So using OneGuide, on the same day, provisionals and abutment was delivered. So immediate provisional delivery could eat on the same day. And once the mandibular was finished, more or less, and prosthesis was delivered, and surgery was planned for the maxillary side. Up to this point, one cast was actually on the early stage. So on the sinus side, I did lateral sinus graft first, and once that becomes stable, deliver implant at once. So for this patient, for the mandible side, OneGuide in the narrow bone, good positioning, the implant was delivered, good position, so the prosthesis is well maintained. And also on the anterior side, the result was quite good. So on the maxillary side, again, I did a through lateral approach. Bones were regenerated, and after waiting for 3 to 5 months, like this, full Edentulous, I delivered, with the lateral anchor guide fixation, and I think this is good approach, and fixation on the patellar side is very favorable. But if the position again is not very good, it can push toward the anterior side. So fit checker needs to be used, or when you do fixation, you have to be very careful. And after fixation using the tissue punt, you remove soft tissue, but sometimes it cannot be removed very well. So I loosen it, I remove it, and do it again. So anyway, implant was placed quite nicely without much troubles. And after this is after removing the template, I already created abutment on the back side. The fixation was rather weak, so here I did not do the same day loading, so used low healing for submergence, but for other area the immediate loading and PMA was done. So like this was the result, and on the upper and lower side, both sides, implants were placed, and after the prostheses were created and delivered. So after even 1 year, satisfied with the results and can eat very well. And it's very much functioning. So using the guide system, if you have good fixation in the good position, you can place the implant very successfully. Another case. So for this patient, it's tricky. As you can see, the existing implant, the bone resorption is severe, and it's even linked to canine, and there's a lot of resorption, as I said. Even the extraction, immediate implant placement would not be easy. So doing a stretch, extraction and immediate placement at the same day, I do not think is the way. So for this type of patient, you extract the teeth first, and the surgery area needs to be prepped first. So as you can see here, the implant was not really good condition, so it removed using the AOS collagen. The big defect area, socket was preserved, ARP was done, and the other side, same. Implant, existing ones were removed, and inflamed area were all removed, and BIOS collagen was used on the opposing side. And I did socket preservation at first, so that it can be in good conditions for surgery later on. So, patient lives like this, so what do you do? It's very important to create temporary denture for this type of patient. The conda positioning and other things, you could check where is the comfortable position. So bone were regenerated after full wait of the 5 months, and after that, doing the full mouth implant placement is the better approach. Of course, if there are few good teeth without mobility, it would be good, but from the beginning, it's very mobile, the positions are all accurate, and the teeth are in bad conditions, or implant is vertical conditions. So it does not really help you in terms of vertical dementia, or setting the positions or getting fixation. So it's better to prep the site so that it can be in good condition, so you can gain more stability before doing the surgery. So complete denture was to be used on the upper side. So on the lower, 6 implant placed and guide was delivered. And if it's not fixed in the position, it can actually move right, left, and right. So using the anchor pen, I put them in the place. I drew them, placed the implant, and the guide template were removed. And that position here, 1 fit abutment was not used, but here sensible abutment was connected, and it actually fixed and had a lot of good stability. If it was immediate implant placement with the abutment, doing trim the same day would not have been possible, I'm sure. But all the bad implant was removed, socket was preserved, and the contour was recovered. And as a result, I could gain a lot of stability. So in the bad condition, rather than the immediate placement with the surgery, it's much better to do this type of approach. So provisional was connected and it stabilizes things, so a prosthesis can work more stably. Even if you use it as a segment, it's easy to set, but there's no cross-arch stabilization. So if you chew on the other side, the initial stability of the implant can be broken. So you have to be mindful of those things. So, but if with the OneGuide system, in most cases, it's always fixed very well into position. So you don't really have to worry much about it. But anyway, it was transferred, and then the occlusion was set and checked, and in time of surgery, this was the video and gaining stability like this. It's really moving, and because of that, like the white bleaching and lateral anchor pin is drilled first to position it, and rather than the back side, it's better to do with the center side first to make it more stable. And in tightening one side and not going to the other side, one side, the other side, and the other side too. So here drilling. So it's zigzag, crisscross. So in the both arts, doing the zigzag step and zigzag step, I do believe is much favorable. So again, implant by place, prosthesis was delivered on the same day, and like this. Final prosthesis, of course, it needs to be segmented and divided, and it's very much functioning even to this day. Today, I talked about the in full Edentulous patient doing the OneGuide surgery, but how doing the vertical dimension, other things are same also to be considered beforehand. This is my lecture for today. Thank you very much.